First of all, thank you for the opportunity, and I wanted to just be sure that we start with a clear understanding that transformation of healthcare is a challenge all over the world, not just in South Africa. Most countries, there are similar factors which prevail. We have aging population, rising costs, and greater usage of technology, early detection of medical conditions, all of which give rise to more treatment during one's lifetime. And governments over the world are under pressure to find new ways to fund healthcare costs, and in some instances they are being forced to cut back on state-funded health benefits. And these debates and trends have prevailed not just recently, but for many years, probably over a decade now. At the same time, access to healthcare is increasingly recognized as a basic human right, and patients are who require treatment expect to receive this care timelessly, safely, and affordably. And the demands and expectations keep growing. And I think the South African landscape, we all know, has additional challenges. We accept these. I'm not going to go into them. You know them all. And private healthcare, I think, definitely stands and wants to be part of the solution. I think as a country and as a policy, there's already a transformation plan. It's leading us towards national health insurance. It's a big and noble plan. It aims high, and it will assert itself with growing insistency. It will survive all of us sitting here today. And the opportunity for the plan to impact and improve lives is enormous. For sure, it will be remembered. But with all plans, it's more a problem about the implementation. And the implementation is critical to the success of a plan. Can we reconcile the practical and the ideal? Nobody's questioning the ideal of the plans. But the plan's going to depend on many factors. Let's start and look at our economy. We've just gone through a budget presentation. The world is slowly coming out of its recession, talking about a slow period of growth, but interest rate cycle moving towards increasing. Maybe in the next 4 to 5 years, we could see interest rates going up to 2, 3, 4%. Our hospitals are built by the large. The bricks and mortars they built. They're built where they are. We can't change that. The demographics are moving around. And some of our hospitals that used to be at the center of some activity are no longer at the center and are isolated. Some of the hospitals are full and some of the hospitals are empty. These are practicalities that are not easily changed overnight. Business in any industry is willing to invest and it's usually willing to take risk. However, if there's uncertainty, there's a lack of clarity, business decisions get delayed. It's not that they don't buy into a plan. It's not that they're disloyal, any of that stuff. Business is business. Business is about capitalism, and certainty, if it doesn't prevail, causes procrastination of decisions. Third question, can private and public health care coexist? I know it can coexist. I've seen it coexist, and I've seen the coexistence growing in the UK. Today, if you go into the UK hospitals, some of those hospitals that are private, 30% of those patients next to each other in wards of public patients in private hospitals. It can coexist. So what is the problem? I think when we want to work towards a rapid implementation of the plan to deliver easier access to healthcare, it would be better if the public and the private hospital industries could cooperate. It would be better than competing. Capital costs of building hospitals, the equipment costs that are required to be put into the hospitals, these are all pointers that point us to say that these resources are scarce, they have to be better utilized. In many instances in private hospitals are only active Monday to Friday, and even then maybe it's Monday to Friday lunchtime or Thursday, and a lot of equipment and facilities are vacant, underutilized. At the same time, the state hospitals are overflowing with patients. There are instances of successful private partnerships in the sector. Not many, but there are few, and there are few that work very well. But they're not easy. If you don't have a public-private partnership which guarantees volumes and is very clear about referral patterns and payment patterns, they very quickly turn into a nightmare for investors. And once burnt, people are twice shy in this regard. But I think if there was more cooperation, we would definitely be able to help each other more through public-private partnerships. And when patients get ill, they all want to get better. It's a common factor. My question is, who's going to pay for that treatment? If you're expecting private healthcare to subsidize, there's a very limited ability to subsidize. If you're expecting government overnight to pay all of these costs, there's no budget. So the parties are forced to work together to find solutions and models that work better. Now, here lies the interesting thing. Over the last 3-4 years, you've seen medical aids steadily provide products which are cheaper and more affordable. Yes, they don't give you all the bells and whistles, but they buy you their hospital treatment and they buy you certain benefits. Your minimum prescribed benefits you can still get at any state hospital. But we're seeing our medical aids, who traditionally are our customers, coming to us with a lot of growth in lower end schemes. And the discussion with us is, how do we provide suitable, affordable, good quality healthcare to those members? And so the model works together, and in the end, 1 year goes by and another year goes by, and the patients are coming on board, and we are serving those patients, and we're not looking for ways to change that. So I think when the partners and the partners in the value chain start working together, there are things that we can do. Private hospitals need volume, because if we've got volume and certainty, we can manage the costs and the risk behind the scenes.
South Africa has embraced separateness. The separateness of before was based on race, and it created a lot of upheaval and was fought as a human rights violation and was called apartheid. I'm not talking about the separateness of public-private, but I'm talking about the separateness of rich and poor. The separateness where previously black has now become presently marginalized. It still remains majority black, but there are a few whites that have fallen through the cracks that are now on the margins, and they are a separate society. Now, the separateness of before, that was based on color, as a black person that lived through that separateness, which was the lower denominator of the two in South Africa, you had better access to healthcare under that separateness than the separateness of today. Now, the separateness of today gets couched in public and private. If you're dependent on the public sector today, you're equivalent to the non-white healthcare of yesterday. And you are worse off today than the black care of apartheid years. Now, access to healthcare at Bar when I was a child was better than access to healthcare under some of the comprehensive, expensive medical aid schemes of today. So you had a public healthcare system that served whites, which was superior to any healthcare system anywhere in the world. It was accessible to all whites for no payment. So the notion of medical insurance, we've taken it from the US and we do it as the US does it. And they introduced medical schemes to a system that worked perfectly for the white population. It also worked imperfectly for the others. But it worked much better than the systems of today. I mean, I will challenge anyone and tell them that black healthcare of yesterday was better than private healthcare of today. And I can back it with facts and with case studies and case histories. We have to be one pot as South Africans and people that live in South Africa. And the provision can be from anywhere. I will concede that public provision has been systematically destroyed. And private provision seems better in many respects. There are many other respects where public provision is still better than private provision. But those should just be mechanisms to provide. And they should provide to all South Africans. And we need to go back to being one nation. Because in health, apartheid thrives, apartheid lives, and we've basically been outwitted by the architects of apartheid in health. So what was white privilege has been privatized. And an act of apartheid that still exists, that has just been tweaked there and there, is the Medical Schemes Act. And it was an act to preserve apartheid. Now, where did we go wrong in terms of transformation? Self-hate. That's where we went wrong. Because you see, suddenly we were still in the struggle. And suddenly some white businessmen went to Lusaka and suddenly, hey, everything is over. There's CODESA. And we who were oppressed, were never really ready to govern. We never really knew what we wanted. We were so oppressed that all we wanted is to stop being denied. But we had never prepared for what we want. So what are we left with? A white dream. So we all want to be white. So we take to BEE because we want 26% of a white company. We won't build our own company. We've all run into the white system. And we're comfortable in what used to be white public health. We all have medical aids. We all sit in there. Damn our aunts. Damn our uncles. Self-hate. Our notion of achievement is to be white. We hate ourselves. We are disgusted with our relatives. I mean, when we have a little bit of money, what's our aspiration? To move to a white suburb. Not to build the ghettos we live in. So what is the aspiration? What is your preoccupation when you get a job? It's not to make sure that your aunt has health care, but it's to make sure that you have a medical aid. You want to join the white world. We are white wannabes. That's where we fail. We hate ourselves. We have done certain things better. But are they the things that matter?
Thank you very much.